Now it's on.
I just wanted to give the no. This one?
I'm trying. So that's one. Well, remember the one with the no follow.
I have the
If you pull up Dr. Bull, twist the camera itself is twisted. Right.
Is that about right?
That's why I couldn't hear where she went.
This is that right?
But she doesn't need very many, even if she doesn't follow with us.
Either me or our title.
Good job.
Oh, no. That's me, and this is you.
So starting in June, as y'all have heard, we're going to have medical students. And one of the things that the faculty want to develop is residents as teachers, because y'all are going to have a huge responsibility of teaching medical students, just like y'all were taught. So this is certainly not any kind of definitive lecture. This is kind of get those wheels starting. There'll be some people coming from UAB that know a lot more about it than I do, that are going to talk to you also. But I just wanted to kind of get started, because that's a huge thing. And I think the thing about developing your skills as a teacher is that is what develops your own analytical skills. So it's not, in my mind, it's not a little thing, it's a huge thing. In your analytical skills in terms of deciding what to diagnose, how to diagnose, and then how to treat. So I can just tell you that the things that, like what Dr. Lynch has just been over, I mean, you're going to look back and be thinking, God, you know, something that really was important. I really am glad that we had that. It's not just what is this really? There's really some important things that aren't, I think, what you think are the super didactic things. I mean, they're really important. So that being said, all right. So there's a bunch of things that y'all will be involved in, just like we're doing with y'all now, in terms of being a teacher. You're going to have to help with evaluations, feedback. That's a whole lecture in and of itself. All these are professionalism. You're going to be role models. Teaching clinical reasoning, which really is going to be the focus of this in just a little bit. Direct observation, in other words, you're going to be watching them just like, I've come down to the emergency room a few times and watched y'all deal with patients and work people up. Conflict resolution, I mean, your team's going to be bigger. The medical students are, in this country, are kind of
Entitled. Oh.
yeah, they're not sacred, they're sacrosanct. So you're going to have to be able to deal with conflict and feedback without offending anybody. You have to do that. Team building, helping with interviewing. You might help them with their CV, how to teach them how to give a talk, help them with that. Okay. So what makes a good teacher? You got to relate well. You know, there's all kind of different people, all kind of different levels, all kind of different ways that people learn and relate. You've got to have goals, clear goals. They're going to know right away if you're not wanting to do it, if you're not enthusiastic. You want to be knowledgeable, but I mean, the point of it is not for them to say you're smart, it's so that they'll learn. So it doesn't matter. They might think you're not so smart, but then they might realize, God, you sure were organized, sure taught me how to look at something. They got to feel like a safe learning environment. Again, the feedback is huge. Y'all know that. Y'all are all millennials. And then when you mess up, when they critique you. You've got to be able to say, you know, that's valid, it's not valid, I'm gonna do something different. And then the last thing, promote self-directed learning. I've been talking to some of y'all about fellowship, and some people say, well, this program should be ranked higher, better teaching, whatever, but really at y'all's level, and certainly at fellowship level, the learning is more what y'all do than what the teacher does. I mean, the teacher can direct you, but y'all's the level, and that you're more self-directed. All right, so enhance the learning environment. Again, tailor the teaching to the learner's abilities. Actively involve the learner, just like we do on rounds and in Metacon, and getting y'all to talk rather than listen to us both bloviate the whole time. The students want to be, you know, they want to get in there and see the patients before you see them. They don't want to go down there all the time with the diagnosis. This is the patient with X, and I mean, they want to go down this patient with a question mark. And then you want to help them figure out how they can learn. Right. So, in the best thing is I mean, cases. Obviously, you got all the cases you want. I mean, that's the everybody's going to be every learning student should be case based because it's going to be based on the students that y'all admit. Short, interactive, kind of lectures or sessions, if you want to call it that. Bedside demonstrations, and I think that's where y'all need to hone your physical exam skills this year. I think I saw, 40 patients, 2 thyroids missed over the weekend. So, I mean, that's just part, y'all gotta be thinking, you know, what can I do better? All right, so, it's just one model of about 1 billion models. I don't know if this is the Halanich model or not. All right, so, how do we figure out what's wrong with somebody? Well, we start with the patient's story. We're acquiring data. And then, I mean, I think, like we talked about recently, morning report. I mean, I think probably y'all do the same thing. We used to do at lunch. You think, oh, that whatever the ER doctor said is not right. I'm thinking of another diagnosis. I mean, that might be it, but maybe they're not right. So let's think of something else. So even just with come on down, I want you to see this patient with you know, belly pain and hypoxemia. So you're thinking, what could that be? All right. So you've got some problem, you're developing the problem, you're generating a hypothesis or multiple hypotheses, and then what they're talking about search for and selection of building a script. The script is just, that's your experience, your file cabinet up somewhere. You've seen, in the more patients you see, you've got more scripts. You've got them organized in different boxes, different categories, and you're seeing if what the data you're getting matches. Does it match one of those scripts? So I'm kind of going down those scripts. All this you're probably doing subconsciously, but that's when you're teaching, you're going to have to kind of pull that out. So to help the student, because they're not going to have all the scripts right off. So we've got to be a lot more organized in helping them develop that. Okay, and this is just along those lines. This is something that, I mean, I do this sometimes. So if I can't figure something out, then I make a list of things. And I mean, I just go down this list, and this is just obviously in the mind, just to be sure you're not missing something. See, it's in one of those categories. I mean, in my business, everything, endocarditis can present almost anyway. In the old days, TB, probably for y'all, HIV. In the old days, syphilis. But, I mean, so there's a bunch of, unless you, I mean, the things that I mean, like for instance, toxin trauma, I can remember not many, but patients coming with diffuse pulmonary infiltrates, things, ARDS, pneumonia. Finally, somebody thinks, couldn't figure it out. Well, maybe it's just a reaction to a drug they took. Yeah, that's what it is. Stop the drug, give them steroids, they're better. But so you want to have a framework. The hard things, I think the way you want to do things is just, first of all, you don't want to miss. I mean, the sepsis you don't want to miss, the MI you don't want to miss, the pulmonary embolus. So we're having a GI bleed, you don't want to miss it. So the common, atypical, rare, that's the everyday practical, but then you want the student to go through every different possibility. Okay, all right. Now, so I'm gonna ask for a volunteer, senior resident volunteer. No, senior, okay, thank you. All right, so this is the case, and then, like in the last election, this is gonna be, who was it that Clint Eastwood was like talking to Barack Obama or somebody, but anyway, so the medical students there, and I just want you, just 5 minutes, and you're gonna kind of go over how you approach this. So this 59-year-old man, white gentleman, presents with 6-week history of weakness, fatigue, nausea, lightheadedness, vomiting, progressive weight loss of 15 pounds, history of remote duodenal ulcer and renal calculi, smoked 2 packs of cigarettes daily for his whole adult life, and he says he drank too much for many years. Exam was remarkable only for altered mental status and moderate liver enlargement. Lab, elevated outfalls 245. He's got mild renal insufficiency. He's anemic. Chloride in 111, CO2 17.5, calcium 15.5, creatinine 2.2. In the lab we have so far, sonogram and IVP of his kidneys. He's got a bilateral upper pole renal cyst, chest tray probable fibrosis, and a rounded density in the left apex. So that's what the information the student's giving you, and I want you to just kind of talk to the student, tell them, work through what this could be.
So just based on the history, without evaluating the patient and then without looking at the labs, I would think that the patient has something going on, it's been becoming a weakness and then fatigue, nausea, and like a weight loss. So the weight loss is one particular thing that says it's been a chronic process that's going on. So, and then the weight loss, the process that's giving him weight loss is also causing the rest of the things, and he has a history of duodenal ulcer, so my first probability in this patient would have been a GI malignancy. And then the second thing that he has smoked 2 packs of cigarettes every day, and so that takes me to other diagnosis, probably a pulmonary pathology. And then so I would be looking more towards a chronic medical condition that has been going on and made him come to the hospital today. And then on examination, I would look for signs of whatever is complaining. I would like to correlate all these things, and then when physical examination is said was unremarkable, maybe that doesn't correlate with whatever he's saying in the history. He should have been dehydrated, and then he should be dry everywhere. And then examination otherwise was significant volume status. So I'm not sure why he's altered at this point. There could be a lot of reasons. He's alcoholic for too long. He could be having a what do you call maybe he's drank too much alcohol and then he's not eating. That's why he's altered. Or he just dehydrated and then he could be having a infection. That could be the other reason. So and then the third thing is he has any CNS pathology from his long-standing alcoholism. That's another probability in this patient. And then when I go to the next step, it's I would still like to correlate, nothing on the physical examination that gave me a concern about the previous, things that I thought based on the history. I thought about GI malignancy, the liver enlargement was concerning that it could have got hepatic metastasis. And then there is nothing on the abdominal examination, otherwise a gastric outlet obstruction or that a mass that I can feel for. And then I would have gone to the next stage, looking at the labs, and then he is not terribly anemic. He has a hematocrit of 30%, and then he didn't have a white count, so I ruled out infectious pathology at this point. And then the next stage was I would like to correlate with his history and then examination findings to his dehydration status. He is obviously dehydrated and then has probably has acute renal failure. There could be chronic. I don't have anything to compare from before. And then the electrolytes, none of them are abnormal except for calcium. And then when the calcium is a 15.5, it could be something, he has history of smoking, and then, so this malignancy is one probability, and then his altered status is probably related to his calcium. So that's how I would like correlated it, and then I would have looked at his images, the next thing. So the chest X-ray was the first thing, and then it showed a rounded density on the left apical region. So now we are correlating smoking history, weight loss, and all these things, and then calcium, and then the rounded opacity. So the most likely reason he's having is he has a pulmonary malignancy possibly, and that's why he's having all these symptoms. And then I will discuss the approach about what to manage first, and then.
Okay, but let's just, I thought that was excellent. So, all right, now what anybody else wanted to, because you see, he broke it down with the history and a differential. What does he think about exams? Maybe the exam's wrong. Maybe we're going to go back and re-examine. Okay, did we miss something? Then the lab. Then he said, put it all together. We got this thing in his lung. Maybe that's what's doing it. Anything else you want to add?
So, I would actually,
Go ahead.
first of all, ask this student, what do you think is going on? What would be your differential? Just get his thought process going, instead of starting off on my own, and then as he, starts, he or she, preferably she,
You can't say that!
I'm going to just say one thing. No, I know that's funny, but I promise you, when these students, you can't say anything like that. You can't do that. I mean, you can't do it. It's just, you can't do that. I mean, it's not right, but you could get kicked out of the program for that, believe me. If the student complained, it'd be just unbelievable.
keep it at
So much trouble.
So, just basically find out what their thought process is, and then discuss everything step by step, system-wise maybe, and start from, say, do you think if it's infectious, then what could be the causes? If you think it's a neoplasm, then what could be the causes? And basically, on that, and just get talking with them.
All right.
And one way that I usually do is I take it problem by problem. Like if the patient, he's got 4 or 5 things that's going on. So I would just say, first problem would be, why is he altered? What's causing the altered metastasis? Is his hypercalcemia, as Dr. G mentioned, or is secondary to liver cancer because he's been drinking so much, his alcohol is 245, I want to know what the other liver tests are. Or is it something like TTP that's going on, his creatine's gone. So I think breaking it down with the student problem by problem, what's causing the altered metastasis, and why is his liver function test elevated, or what's this mass in the left side. So I think that could be one way to do it.
No, I
Break
think
it
this,
down.
so it is all, I think that's a good way to do it. I mean, what,
The other way I learned from Dr. Abraham is, once you present everything, you make like a problem number 1, and you make it from, okay, what are the findings positive with history and lab on examination that's going with that diagnosis.
So not problem number, but diagnosis number 1.
Yeah,
That's what you're
diagnosis
thinking.
number 1. You say in this guy, if it's too early, like within 1 day, say altered status. Okay, on history, how long it's been, he has any baseline dementia on them. Okay, on examination, he's oriented only to one. And on labs, I find because his calcium is high. And so it's like a systematic approach. So
So that's sort of what I was going to say, is basically start with the illness script. So when you have more, when you really experience, I looked at this guy and thought, does he have cancer? Is he infected? Those were my first, like really broad illness strips. I got confused, weight loss, abnormal labs. I mean, not even looking at the details. And then I go back and then go through and see, then I go through and see which one it is. But we as physicians are sort of trained to be pattern recognizers. So that's just another even broader way is, real quick, what does this look like to me? And then let me rule it in or rule it out based